Lord Oakley, I went through your abstracts and I came across some very interesting things, very new for Taishak, very new for people like us. And you have very clearly mentioned about teledermatology pathways in New Zealand. Could you explain a little bit about that to us?
Well, these pathways are really only in my institution. Like everywhere, we know what we do in our local area, but I can't speak for the whole of New Zealand, really. It's just what we do at Waikato.
So, how does that function? Can you explain to us a little bit?
So what I'm planning to talk about in the meeting in November is really the history of how we got to where we are at the moment. So at the moment, we separate really skin cancers or spots that are suspected to be skin cancers from inflammatory rashes. And we've concentrated mainly on the skin cancers because we just have to look at the lesion to know what it is. With an inflammatory rash, it's more complicated because we need to ask a lot of questions and examine the person over the whole body. So we have an epidemic of skin cancer in New Zealand. It's very, very common. We have more skin cancers than anywhere else, together with Australia. And we don't have enough skin specialists to make a diagnosis on all these skin lesions. So most of the time, the planning is done by the primary care doctors, but they don't have the skills and experience to do that. So we offer them assistance in making a diagnosis by using photographs. And over the years, the photographs have got more sophisticated. So at the moment, we run two projects. One is called the Virtual Lesion Clinic, and the other is called Suspected Skin Cancer e-triage. So I'll deal with those separately. So the Virtual Lesion Clinic began in January 2010, so it's been going for more than 8 years now. And so the primary care doctors that refer to our hospital, to the dermatology department, we arrange for the patients not to see a doctor, but in fact to see a nurse in one of three places. And the nurse takes the history from the patient and also photographs the skin lesions. And the photographs are very high quality, which means it's easy for the dermatologist to make a decision as to what the skin cancer might be. The problem with that system is people still have to wait a long time because we've just created another waiting list. This time it's not for the doctor, but it's for the nurse. And it's relatively expensive because we have, the nurse has to have somewhere to work and has to have special equipment. But it's very high quality. So that system is run by a company called Molmap New Zealand, a private company, but our hospital contracts that private company to provide the imaging. So it's an unusual, we call it a private-public collaboration, and there's not very many of those, mainly private and public are kept separately. So with that system, we've been able to make very high quality diagnoses, and 4 out of every 5 patients, they don't need to come to the hospital because they don't need any surgery. So the GP might have been worrying about their lesion, but it was ours. And the ones that need to come to the hospital, well, we still organise for them to have surgery. So the second system we have, we just started a year ago, and that's using our normal referral system. So since February 2016, the doctors in the community refer over a computer over an internet link, and that's called e-triage or e-referral, where E stands for electronic. So that arrives in my on my computer almost instantly the moment that the doctor has sent it. And if they fill out a special template which has got all the right questions on it and attach the right kinds of images, then we can make diagnoses using that system too. So the advantage of that is it's very quick. So instead of waiting weeks for an appointment, we respond to those within 2 or 3 days. So that's good. It means the patient is less anxious about what might be a skin cancer, and the doctor doesn't waste time doing the wrong thing. If they need surgery, and again, it's about 1 in 5 does need surgery, the primary care doctors can decide whether they do the surgery themselves or they send the patient to a private surgeon or whether they send them to the hospital. The disadvantage of that system is we're depending on untrained photographers, and the photographs vary in quality, so we're trying to increase the knowledge of the doctors and trying to train them. Now, most of the pictures are taken using their smartphones, and we ask for them to take a picture of the skin lesion itself as a close-up, and also the region of the body where it comes from. So if the lesions might be on the back of the hand, we need to see the rest of the arm really to make our minds up as to what's going on and what would be the best treatment. And then we use a special magnifying device which is called a dermatoscope, and this can be stuck onto your smartphone and allows magnification of 10 or 20 times. So we can see the structure of the skin cancer much more reliably, and so if we get good pictures, it's just as good as the virtual lesion clinic. Unfortunately, we don't always get good pictures, but we could always ask them to refer to the virtual lesion clinic if that system hasn't worked. So we're busy evaluating that. We're doing a lot of research looking at whether that's any good or not. And that's resulted in a lot of the doctors beginning to ask for advice of other types of skin problems. So they might have a patient with eczema or a patient with a rash that they don't know what it is. So they're starting to attach pictures of those conditions as well. And we will be developing a specific template. Now, none of this is really new. We've been doing it for a long time in different ways. But what we've managed to do with this new e-triage system is make it work as normal. So the doctors in the community, they're used to referring their patients to the hospital using this system. So, and the system keeps a record of what they've done, and then we keep a record at the hospital. So it's kind of work as usual, whereas our previous telemedicine or teledermatology projects had all been something separate and aside from their normal work. So it's been quite an interesting journey, really. But we're managing to reduce unnecessary surgeries, because previously they might have just cut something out that didn't need to be. And we're helping the primary care doctors make a diagnosis. It's not perfect because we don't take the history from the patient ourselves and we don't examine the patient properly. So we're depending on really good primary care doctors. But luckily we've got those. But you know, you've been doing this kind of thing in Nepal for many years.
Yeah, Dr. Oakley, the thing is, because there is a sort of an absence of trained personnel and skilled technicians in the job. So that is making somewhat difficult in the full implementation of the system, see? So I have one question on that a little bit later, but if you allow me to just ask you one more, that you have a quarter-century experience in live, interactive and store and forward teledermatology systems in New Zealand. How is it worthwhile? Do you have any problems? Are people receiving it very well, positively? How is it going on? with 20...
Well, it's sort of work as normal now, and we don't really think of it as being something special. It's just normal work. So I guess they're used to it, because everybody here has a smartphone. I dare say they do with you as well. Everybody has some kind of a smart device, don't they? And they can all take photographs. So it's just normal now.
Yeah, to my knowledge, ICEHAT here itself is not somewhat trained personnel in the field when they are conducting e-health or, let's say, telemedicine in different corners of this country. But Nepal, being a mountainous country, certainly poses great problems and risks for people, because people aren't highly trained. They have to learn even more and more. That's why ICEHAT wants to share with you when you come to attend ICEHAT, this conference in November in Kathmandu this year. Most of the doctors I've spoken to on Skype, on Zoom, regarding the forthcoming conference, all of them, they spoke about electronic technology, digital technology, and using the most advanced method of, say, computerized techniques and so on. So
that's true, but it's very cheap. The old-fashioned way of writing a letter and printing a photograph and sending that was very expensive.
People are using computers everywhere. You will find computers everywhere, most of the hospitals and everywhere, in health clinics and so on. They are doing it, but they still complain that they just lack some kind of know-how and expertise in handling this technology with full satisfaction. And now coming back to this question, how feasible do you think, as an experienced doctor in this field, about ICEHAT working with a technology like this in a mountainous country like Nepal?
Oh, well, I'm not qualified to answer that sort of question. You need to ask a telecommunications person. But, you can use satellite, or wherever there's mobile or wherever there's internet, it can be done.
Yeah, like I told you earlier, ICEHAT is conducting some of the successful projects in various nooks and corners of this country. Let's say about e-health and telemedicine, and I've visited one or two projects with the doctors, even with the chairman of ICEHAT, Professor Dr. Anil Kumar Jha, and they have been doing quite a nice job. But still,
There's about, I'm just looking up on the Swinfen Charitable Trust, they have about 30 centres in Nepal, including in Kathmandu, for their website, which is a very straightforward form of telemedicine, and as I say, I've been working with them for a long time. So they, I don't know the names of these places, but I don't know if they're, what have we got? We've got Kathmandu, Dud Party, Dulikel Hospital.
in hospitals,
Mugu, Hamla, Circuit, Kundi, Lunka, lots of places. So they've managed to have communications in quite remote places for many years.
Yeah, what is more conspicuous in this sector, according to you, is actually our telecommunication system must work properly and effectively.
That's right. Yes.
So, Dr. Oakley, now allow me to come to another subject of yours. I read your abstract and it says DermNet New Zealand, right?
Yes.
DermNet New Zealand. Is ICEHAT a member of DermNet New Zealand?
It doesn't have membership.
Ah.
It's a free website for anyone anywhere in the world.
Yeah, but this ICEHAT this Skin Health and Referral Center, Kathmandu, is not a member of DermNet New Zealand, right? Is it a member?
We don't have a membership, so nobody's a member.
I see. Hope
It's just a website with information. So we've got about 2,500 pages of information, free to the world, on skin diseases. And DISHARC is very, very welcome to use its information. And we do have translations into different languages as well. So let me see, what language do you speak? It would be Nepali?
Nepali, yes, that's right, Nepali.
So we have translation through Google into Nepali.
Oh yeah. All right, Dr. Oakley, my final question. How excited are you to come to Kathmandu in November?
Oh, very excited. And I'm wondering if I could arrange to come and see DISHARC. I find that very interesting.
You are most welcome.
Mm.
And then any message you are bringing to DISHARC?
Oh, best wishes from New Zealand.
Ah, that's great. Okay, Dr. Oakley, that's very kind of you. Thank you so much from the very core of my heart. Thank you once again and namaste.
Namaste.